just don't exist or don't take Medicaid in general, mostly. So that's the answer to that question. The relative question of do we use a minimal network to manage utilization? I think that one of the things is that is certainly not our preferred approach. What we would prefer to do is we prefer to manage medical care. We would prefer to improve the healthcare outcomes of our members, and over time, we have full confidence that that's going to occur. However, we do face financial pressures today. And those financial pressures have had us make some decisions we'd rather not make. And for AmeriGroup specifically, dental has been an issue. And we have tried to manage our dental costs in many ways, but it's been a challenge. And one of the ways that we've had to do it is we've had to reduce our fee schedules pretty significantly. We really would rather not have to do that. But the issue is that we have to live within a budget, just like any other business, whether you're a provider, whether you're the state, whether you're a family. And we're doing our best to manage that. So we've had to take that action, unfortunately, but that's where we've had to go.
Hey, Craig, I have a couple of questions. Let's talk about dentistry. You're talking about losing money. You are, as a CMO, losing money on dentistry.
We are, as a CMO, losing money. We are.
Why is that?
I'd be happy to explain that. When we received a data book, the process of us bidding on this program was such that we received a data book from the state, and that was the claims data that they had at the time. At the time, that data was 2002 and the first couple months of 2003. We took that information. That information told us that dental was running at approximately $13, less than $13 per member per month at that time. We knew that there was going to be moderate trend, increases in the cost, even though the fee schedule didn't really change, but also there was going to be some minus managed care savings to offset that. We budgeted 13 and change for our dental services because we also compared that data with other states and didn't see anything unusual. As it turned out, something happened between 2002 and 2003, and there was a significant influx of providers, and there was a lot of hard work done by the dental community to improve access to care, and we applaud that. At the end of the day, we've been losing $1.5 million a month on dental. And we've had to address it somehow. And we have had multiple conversations trying to change that so we didn't have to take that approach. But we've heretofore been unsuccessful and had to do that.
What is wrong with the increased care for children, even though it's costing more? I mean, I understand.
Absolutely nothing, but it needs to be funded.
So are you saying that we underfunded the program?
We feel that the program is, the revenues that we get is not sufficient to provide the level of services and the price for services that we have today.
Okay, so we are underfunding you. At this point, though, do you feel like you have an adequate access or network of dentists?
Absolutely.
So if we're underfunding you, how do you at this point have an adequate network of dentists?
I don't understand your question.
So at this point, you said we've underfunded you and you're losing money and so forth. So how, with all your changes, do you have an adequate network?
Well, we have gone ahead and executed a fee schedule reduction, and some providers have selected to leave. But given that we only serve 20% of the population, we do not have to have as robust a network as the whole fee-for-service program. We do have to have absolutely enough providers to serve the members that we have. We have 772 providers in our network, and based on the information that we have, and we are, again, continually monitoring that for pockets where there's underutilization, and we'll address that with physicians in those, or dentists in those areas. We will make sure that we have access to services for our members.
And you, as AmeriGroup, do not per se handle the dental. You have another group do it, Doral, correct?
Doral does do that for us.
Right. So we have two corporate structures here that we're having to try to pay for. If for some reason we are not able to increase the funding for this, then how are you going to handle this dentally?
Well, we'll have to live within the budget that we have, and we might have to go other areas as well in managing our utilization and some of our other costs. One of the things we've done is we've tried to manage our own administrative expenses. In fact, we've had the unfortunate experience of having to lay off 17 FTEs. These are FTEs that we think are valuable to the program, to Georgia, but we've tried to take some pain and share in that burden as well.
And, we don't want you losing money. I understand that. But if there's two corporate structures that we're paying out now, obviously to Doral as well as Amerigroup to do the dentistry, wouldn't it seem logical if we decide not to fund that we should get rid of one of the tiers and, as we've talked about, carve out dentistry or whatever, and then just have one? Because there are other states that Doral is the administrator and there's no corporate above them that's got to take a piece of the pie. So would that not be in Georgia's best interest to, instead of having two corporate structures that we've got to pay one? Would you support that, knowing that you're going to lose money in dentistry if we don't fund it anymore?
Well, first of all, the issue that's driving the dental expense problem is not the cost we pay to Doral. If we pay that money to Doral, or the state pays that money to Doral, or some other benefit manager does it on their own, that money still needs to get paid ultimately out of state dollars. The issue that's been driving the expense to a great extent has been the utilization and the mismatch between the expected utilization and the actual utilization. If we give dental back to the state, which we'd prefer not to do, and by the way, we don't intend to make a profit on dental, we just can't lose as much as we have. If we give that back to the state, then the state is going to be faced with paying for that utilization. And if that's a policy decision that the state wants to make, we understand that. We'd be happy to work with the state on that issue.
Okay, thank you. One more question, and I'm going to ask all three CMOs this. Can you absolutely stand before us today and say that there are no built-in systems, no policies in your organization that denies a high percentage of initial claims or delay claims processing?
I absolutely would say that is not the case. We do not do that. But I will also say this, we're not perfect, and we do make mistakes, and we're working to address those. But we don't have systematic intent to not pay a claim.
Okay. Under Georgia Medicaid policy, you have 180 days to file a primary claim. You have 365 days to file the secondary claims. Amerigroup is just 120 days no matter what. Why the restriction there?
Well, first of all, we live within the contract that's with DCH, and it says 120 days, not less than 120 days. We utilize that. 120-day standard is not uncommon in the industry. But I know there were some comments made about refiling of claims. We actually start the tolling mechanism in our system from the time the last claim was denied. So if a claim was denied, we will start tolling that time frame. You get a do-over on our timely filing. I would also say that, quite frankly, in our relationship with a lot of the providers that we've had in the state, especially due to some of the initial issues associated with our misunderstanding of their expectations and maybe some system setup issues, we have waived a tremendous amount of timely filing requirements and have paid the providers. Some we haven't, because there's multiple culpabilities, including from the provider, but where we've made that mistake, we've waived that need.
Thank you. At this time, I recognize Representative Stevens for a question.
Thank you, Mr. Chairman. Did I hear you say that your company's not making money?
That's correct.
You're losing. How much are you losing overall?
With the Department of Insurance, which is a publicly filed document, our quarterly insurance financials, we've lost $19.9 million in 2007, first two quarters. We lost $17.8 million in 2006.
Strictly as a result of Georgia Medicaid and Peach Care?
It is only for Georgia Medicaid and Peach Care.
Okay. The patient, Diana, that just came up short just a few minutes ago, real touching story. Did she have the opportunity to get these drugs at a local pharmacy, or is it in their clinic, or for the MS? Was it mailed to her?
Usually that falls under our specialty pharmacy, so it would be mailed. It
would be mailed. Well, we heard yesterday from a patient that was at the a father at the end of the day, these 100-plus degree temperatures where they just kind of threw it out at the front door. Might want to look and make sure there are temperature strips in these things. And last thing, whenever it comes to pharmacy, does your company receive rebates for using preferred drugs?
We do collect rebates because that reduces the cost the state needs to pay us to cover the cost of the medical expense for the member. So it would be remiss on us if we didn't. We do not design our formulary based on what we get from rebates.
Mr. Chairman. A couple of questions down at the, one at the provider level. Yesterday we had testimony that small rural hospitals were having to manually fill out forms when appealing denials. What are you doing to set up the necessary codes so that they can put these denials electronically?
Well, I think the issue is claims adjustments, and that we are working on that system to get the same or similar functionality as ACS. Relative to the appeal denials, those currently are a manual process.
Are you doing anything to make it electronically?
I'll have to check on that. I'm not aware that we are at this point in time. But refiling of claims is what I'm talking about. That's a little different than if there's a medical appeal denial and we need clinical information.
Well, can you do something?
We can work on it, yeah.
Okay. Second question, and I think it's follow-on to the chairman's question. We had testimony yesterday that in particularly some of the rural hospitals, you automatically paid $50 for the emergency room, and they had to appeal to get more than that, but I believe your testimony this morning said that that's not true?
Not for AmeriGroup. It's not an issue for us that we're aware of.
And my last question had to do with the obesity on page 3, the diagram. Recently, last couple of weeks, there was an article in a number of the newspapers pointing out that, what do they call it, gastro bypass surgery was improving people's lives, extending it, and they were making them healthy. Does Medicaid cover that particular operation?
Yes, it does, but there's medical criteria that need to get passed before that avenue is pursued, because it is a dangerous surgery and not always successful.
Thank you very much.
Thank you. Recognize Representative Hughley.
Thank you, Mr. Chairman. Can you tell me if your contract has been amended, the contract that you have with our state office?
It gets amended for rates, and there were some minor amendments that were done. Kathy, when was that? Like late 06?
So how many amendments has the state given to you on your contract?
It's 2, as I'm aware of, yeah.
And how many amendments have you given to providers on the contracts that you have with them?
For primary care specialists, hospitals, none. For dentists, we have done 2 that we've stuck with. We proposed an amendment to go to a subcapitation arrangement. It was our attempt to, instead of giving a broad-based fee schedule reduction, to give an opportunity for some providers to evaluate their business and say if they wanted more volume at a lower price, and us being diligent about the cost that we spent. We did try that. We decided, based on the comments from the providers, even though we still met network adequacy, to abandon that because of the dissatisfaction from the provider community.
Speak to us about what I guess would be a chargeback if a member is determined later after service is provided not to be a member at the time of service and you pay them. How do you handle that? And is the provider the only person in the scenario who absorbs the full cost of that when both you and the provider at the time of service assume that the person was eligible?
Yeah, the issue about retroactivity, there's no question that that's an issue, and I can tell you that's an issue not only in commercial health plans, it's also an issue in other Medicaid health plans in the states we're in. One of the things I'd like to say about the state of Georgia is we've been very pleased with their treatment of retroactivity, and despite some of the comments that were made in the testimony, which are absolutely real, the problem in other states is much, much worse. I actually was the chief operating officer in our Maryland health plan, and I got retroactive denials for up to 3 years and longer. And we are required by our contract here in Georgia and every other state we're in, because this is federal money, to collect that money from the providers. We do not like that process any more than the providers do. But our hands are a bit tied on that. What I can say for the state of Georgia is there are a certain number of members that are subjected to that. As Kathy mentioned, on the 25th of the month, we get our initial files, but then after the 1st of the month, we get a voids and terms file. That void and terms file actually removes members that were given to us initially, And until that's processed, there's a few days where we think they're eligible when in fact they may not be. That void in terms file is typically about 1% of the membership in the program.
Do you have a recommendation for how to rectify that so that the lowest person in this scenario doesn't absorb the full cost?
Well, I think that if you want to eliminate retroactivity in total, that would be a cost increase to the state ultimately, and that's a policy decision the state needs to evaluate.
I have two other questions. The first question is, explain to me, if you know for dentistry what the standard of care is, you got a number of members that you're going to take care of, how overutilization comes into that process.
I'm not quite sure of your question.
You know that you have, let's say you have 100 children that you're going to cover, and you know what the standard of care is for children who need dentistry. So tell me, I don't understand how you could not anticipate what the costs were going to be to serve that population, is what I'm saying.
The reason why we didn't anticipate the cost is anytime you're actually looking at the cost of health care, and this is done by commercial plans and this is done by Medicaid and Medicare, you look at what had happened just most recently, and then you make assumptions about changes in that. So while we absolutely have no problem with giving 100% of services to 100% of the members, we just need to be funded appropriately to do that, and we'd be happy to work with the state on that issue. What I was alluding to was the fact that the expected cost versus the actual cost are dramatically different, and that's a problem that we're trying to work together with DCH to address.
I still say that I don't understand that based on the fact that there is a certain standard of care, and that should have been part of your assumptions, not just what had previously been done, because you're trying to take us to a higher level of care than we had previously experienced. And we're going to leave it right there. My last question for you has to do with this call to action on your provider satisfaction survey. I had to put my glasses on to read it, but it says two things about timeliness of pre-certifications and timeliness to answer questions and resolve problems were some of the things that you have on your call to action that the providers say you need to work on. How are you handling all of these call to actions? Those are just two examples.
Well, I could go through every single one of them and talk about initiatives, but relative to those two things, if you recall, we did the survey immediately after Go Live. At that time, we had two issues. One of the things relative to the prior authorization process was that we were somewhat overwhelmed with some of the prior authorization requests that we actually received. Early on in the year, our performance was not what we wanted, but Dr. Clark and her staff has corrected that issue. So going forward, we absolutely expect that that number will improve. I'm sorry, what was the other? Was it claims timeliness?
It's timeliness to answer questions.
Oh, answer questions, yeah.
And resolve problems.
Yeah, timeliness to answer questions, that comes from many places. It comes from our provider service reps, our medical management folks, call centers that deal with provider services questions. Our metrics relative to our national call center have improved dramatically since the time that survey was done, and we're pleased about that. However, one of the initiatives that we have at AmeriGroup is, while we may be able to answer the phone, if we can't answer the question, then what was the point? So we're trying to improve our first call resolution and enhance the training of the folks in our call center to address those questions immediately rather than taking a message and calling back. And we think that's definitely an opportunity for us.
Thank you. Thank you, Mr. Chairman.
I'm sorry, Dr. Clark.
I wanted to make one comment about both of the surveys. Just so you know, with all the surveys, once we get the results back, we pull an internal team together to develop an action plan for those areas that are outliers, where we think there are opportunities. And then we come up with that action plan. We actually take it to our medical advisory committee, which is made up of participating providers that we're contracted with, and make sure that they, number one, see if they have any other additional recommendations to add to the action plan, and then to get approval to move forward with those interventions. And we do that with both the member and the provider survey, just so you know. And so all of those were addressed.
Excellent. Thank you.
Recognize Senator Thomas for a question.
Thank you, Mr. Chairman. I certainly appreciate your presentation. Earlier, you had mentioned, I think, 150 full-time FTEs.
Yes. That's just in Georgia.
Just in Georgia?
Yeah, we have probably another 700 people supporting us in our home office.
Okay. You also mentioned that you may lay off 17.
No, we did lay off 17
You did lay off 17. The social workers and case managers, are they doing dual roles, or you have separate caseworkers and case managers and social workers?
We have, I talked about our behavioral health department. We are the only CMO that actually insources this behavioral health services. So at the plan level, we have a department of social workers, and over that department is a master's level social worker, and we have a part-time psychiatrist that support the behavioral health program. Then we have under our regular medical case management program 3 social workers that really assist the medical case managers around those social needs that I mentioned earlier.
So total social workers and case managers, how many?
If you're talking about social workers and case managers, I believe we're up to about 10 or 11.
Could you please tell me how many cases each of them have?
On average, our caseload is about 50 or 60 active cases, and then there are a number of pending cases. So to be honest, their caseloads, I would say that's more of our target. We have seen them closer to 100 cases, which becomes more difficult to manage. But so that's pretty much closer to 100 is the actual experience, but our target is somewhere around 50 to 60.
Okay, you mentioned earlier that in the provider category, there are about 12 pending appeal cases that were denied. How many denials all total, even with your members?
Our denial rate's about 2%.
Okay.
Of the number of members?
Total claims.
Okay. Let me ask you a question about coding, because it seems like coding is a pretty good problem, a big problem when it comes to denials. How often are the codes changed? Who changes them? And how soon do you get the update of the codes? Because you have, in order for a provider to bill, they have to use a code.
Yep.
And there are times when the codes will change. So who make those changes, and how soon do you receive those changes so that your system, what you have in your system, will match where the payment's coming from?
That's a good question. There's many codes that change. There's HIPAA compliant codes. There's Medicare changes that kind of drive that, and there's also decisions made by the Department of Community Health. We have an active process to monitor that in our operations area, and we work diligently to do that. One of the things that absolutely changes every year is the cost to charge ratios for the hospitals. It does take us some time to complete that programming and incorporate that into our system. And we have built into our contracts that expectation for us. And so when we get that information, we update that information according to our contract.
Craig, let's clarify something here. You said 2% of claims.
Actually,
we're not talking about initial claims, though.
Let me mention that. I said claims, but I meant request. So the specific data.
It's authorization request. Authorization request.
Which those appeals are addressing those issues.
I just wanted to clarify that.
Yeah, thank you.
Representative Gardner.
Thank you, Mr. Chairman. In terms of this simplification, I really appreciate that you are including behavioral health services with medical services, assuming that mental health is part of medical care. I was interested in the criteria for approval of services, and you said something about the criteria were going to be online soon. Is that? I mean, tell me a little bit about the criteria for approving mental health services, including psychological testing.
Well, with all of our criteria, we use industry standard criteria. And we have a process within our organization that is peer-reviewed literature, is researched, and is taken through what we call a medical policy committee in our corporate office. And that research is done at that level, and then it's pushed down to the plans. And we have, as I mentioned earlier, our medical advisory committee, which is peer review, contracted providers, which includes a psychiatrist and a psychologist. And so they also review those criteria. Now, In the state of Georgia, you have your intensive family services, for example, and there are no good industry standards around that particular model. And what we've basically done is use what the state has had in place. So where there is clear industry standards around the use of services, that's kind of the direction we go, and then otherwise we would follow the state. And if there's no clear criteria, as a matter of fact, we just in July of this year updated our authorization rules and looked at the number of services that we were actually denying, as well as services where we had authorization requirements, but we didn't really have any good clinical criteria by which to make a decision, and we eliminated authorization requirements for those kinds of services because it was value added for the provider or for us.
Does that include psychological testing?
No, psychological testing, we do have criteria, and I don't have that criteria with me. I can, if you need that, we can definitely get that to you. And the source of the peer-reviewed literature that's based on, we can get that information for you. But no, psychological testing still does require prior authorization. And we do have, the decisions for those are made by a psychologist. It's not, an internal medicine physician like me, or it's someone who's trained.
It's my understanding there's been a severe reduction in the amount of psychological testing that's done on these Georgia families with children with mental illness, and so that's a concern.
Well, there's specific criteria that is used, and we've seen across the board that, in the prior fee-for-service model, that services were being authorized, but they were not being bumped up against any criteria. And so with the implementation of the CMOs, across the board, that has been the case.
In terms of the simplification, may I ask another question, Mr. Chairman? I keep going back to the goals of the department around simplification and wondering, in this new collaborative phase where you and the other CMOs are working together, have you considered, or would you consider, standardization of credentialing, license, and just use license verification and follow up on Representative Amerson? Just let me ask the last part is, what about the sharing of information? If I get an X-ray when I'm covered by AmeriGroup and then I switch to one of the other plans, we're paying for it twice.
Well, I would like to start by saying, number one, remember that we're three different independent organizations, national organizations that have corporate structures and processes. So we have, our flexibility is limited by our corporate policies, and that's the same for the other CMOs. I would say, that being said, that we meet frequently with DCH and try to become as aligned around those things where we do have flexibility to do so. But to the extent that the providers have requested for us to become unified and seamless, where there would be no differences, I think we won't ever reach that point, but definitely we can become more aligned. And I think there's a commitment to become more aligned around a lot of our processes. That being said, number two, what you're talking about is the transition of care. We do have a transition of care policy that has been in place since Go Live, that we've worked with the state. And so when we do, for example, a patient is at WellCare this month, and then the next month they become effective with AmeriGroup, when we identify those patients, if WellCare has authorized a service, we do honor that service, and vice versa. There are challenges sometimes with the providers not always letting us know that this transition has occurred. So we're always communicating as to how can we improve that process and that handoff process, but we are committed to doing that.
So it would be up to the department to set a standard form for you to use in order to...
And we do have that in place. We do have that in place. But again, we're not, with every single member, we're not involved in the office between the patient and that provider at that time. And when that transition happens with another CMO, if they don't let us know, that piece sometimes does get dropped. But again, we're always trying to close that gap.
Recognize Representative Smith.
Thank you, Mr. Chairman. Y'all probably will speak last next time, however. Yeah, I know y'all were hired to manage the health care program and also save the state some money, but if you listen to yesterday's comments, they were very critical of things. And to me, it gave me an impression that they thought that y'all were balancing the budget or saving the state money put on the backs of the medical providers. They've had to hire additional staff. Y'all changed the rules throughout the contract, or some have changed the rules throughout the contract year. Providers have been terminated. In some cases, I think providers have been terminated when there was only one provider in a county in some instances. They've had problems calling the call centers, getting reliable answers, so they didn't have to call back 2 and 3 and 4 times and get different answers every time they called. If it had only been one dentist or one doctor of any kind stand up there and say this, it's one thing. But when you have association CEOs stand up and talk, to me that kind of indicates the magnitude of the problem that's felt throughout the state. And they also talked about taking too long to be paid, and I think I heard the figure that millions of dollars were owed that have not been paid. Do y'all work with, on a regular basis, providers to help resolve these problems so that next year when we have these hearings that, you know, we don't have 6-7 hours of testimony really condemning how the program is operated? I don't think any of them complained of the concept. I think it's all in operation of how it's being handled.
That was a lot there, but I'll try to answer as best I can. Relative to claims payment, our data shows that we do pay claims relatively quickly, but they're not always 100% correct, and we do know that. And one of the things we're working to do is to make sure that the first time the claim shows up, if it is clean and if it has all the information that is necessary and meets our payment policies, which are communicated to the providers, that we pay it quickly and accurately. We are always looking to improve that. But, you know, we also recognize that sometimes providers don't understand what we need to have to do that. So for hospitals, we have joint operating committees. We meet with them regularly to try to address those issues. We have work plans for each facility that we have joint operating committees with, and we work those issues one at a time. Many times there are issues. As I mentioned, we often waive timely filing rules and things like that to accommodate those issues. Sometimes we have to educate the provider to do something differently so that we can work together to make that happen in a smoother way.
You mentioned hospitals. What about dental associations and the other various medical providers around the state? Do you work with them on a regular basis to resolve some of these problems?
Absolutely. I mean, we have talked with the Dental Association routinely, and Doral, our dental benefit provider, works with them routinely. It's been less, honestly, about claims processing on the dental side. On the physician side, we constantly have conversations with the Georgia Academy of Pediatrics, and we constantly have conversations with Pat Code at the OBGYN Society. We also have provider service reps, customer service reps available telephonically, all trying to help and work through those issues. But of the many millions of claims we receive a year, we do make errors. And a very small portion, a very small percent of 1 million claims is still a big number. So we're still trying to work to improve those issues. So again, I could provide a lot of data. The reality is the providers think that there's errors that are out there. Yes, they are. But I would also say generally they're the exception and not the rule. But the exception is the issue that we're trying to address.
Representative Hurd.
Thank you, Mr. Chairman. My question is in reference to members who you have not been able to locate due to maybe not having correct information, and just roughly how many members are those, and what do you have in place to try to locate those members?
2 issues relative to that. The first is our initial contact with members once they become a member. And then the second is what our medical management team does. So I'm going to talk a little bit about the front-end process, and Dr. Clark can talk a little bit about the medical management thing. We get a significant volume of return mail. Addresses are incorrect. Phone numbers are wrong, that type of thing. What we do is we receive all that return mail. We actually go through various databases that we purchased to try and scrub all that return mail and see if we can't find an updated and current address. We even get to the point where if we really need to find somebody for a very particular reason, we will reach out to their last known address by having one of our community outreach people actually go to that location. We don't have enough staff to cover all of that. It's a lot. I don't have the exact number, but I think that it's not as bad as what we see in other markets, which is a testament to the accuracy of DHR and DCH's information, but it's probably 20% or so. Relative to case management, which is critical. Yes, sir.
You said 20% of your, what, 200 and...
Well, we have 220,000 members, but we don't get 220,000 new members every month. So, we're working that constantly, about 5 or 6% turnover every month. Relative to medical management, I'll let Dr. Clark speak. Do you have another question?
And now you say you don't have anything in place, or you just try to follow up through some type of outreach. Did you mention some outreach program that you?
Well, I'll kind of complete what he was my part of this question. We do have, I mentioned earlier, a member outreach program for all new members where we try to reach out and do the clinical assessment when I talked about the integrated medical management process. So, and a good number of those, and I would say about, like Craig said, about 20% of those we're not able to reach. That information, that process is actually managed at our corporate office, and those members are then referred to us at the plan level. And then we do try to reach out, and if we're not able to reach them, sometimes we're able to reach them telephonically, even though our corporate office is not able to, because we have an auto dialer process that is used there. But for those members that aren't contacted through that process, we send out a letter saying we've been trying to reach you, and I'm your case manager, and this is the number to call. And we do have a good number of members who will respond to that. And then after that, really, we're kind of stuck. But then I talked about earlier the continuous case finding process. So if we identify through the utilization process, through looking at claims data, patient ends up in the hospital or the emergency room, then we will then, and so we definitely want to intervene with this patient. We know the contact information we have in the system is incorrect. We call the treating physician, the hospital, the pharmacy. Our case managers make those kind of calls to get a more current data, current information, and then to outreach those members. So we have a number of mechanisms in place to try to reach the ones that are at least highest risk. To do that across the board for 220,000 people becomes, we just don't have the resources.
So that's roughly about 40,000 people that you're unable to contact, roughly.
Well, that number is constantly changing because that was the initial number we get, and we draw down on that by the activities done by Dr. Clark's area and then also our corporate offices and the outreach that we do. So we minimize that over time, but we're always getting new members. And a lot of those, kind of replace the ones that we can't contact. I wouldn't say that 40% of our members, or 40,000 members, we can't contact.
Well, you said 20% of
20% coming in, but then we work that list.
Yeah. So let me ask you this. So you don't really know whether or not what they're costing you unless they go to the ER or some other source, right?
Well, of course we know what they're costing us because we get the claim. But that doesn't mean we make a phone call on every claim we get.
I understand that.
We don't necessarily go after every person.
Right.
Because there's preventive, if they're getting their immunizations and their health check services, we're doing an outreach from that perspective, but it may not need a case management intervention. Right. And so, we're really trying to identify up front those members who are at highest risk and be proactive through that telephone outreach process. But if we're unsuccessful, yes, we do use claims data, so yes, we're a little bit reactive in that case.
That's my whole point.
Yes.
When you're trying to get to those before they go to the ER.
Yes, and we have infrastructure and processes in place, but again, it's not 100% proof.
Okay, thank you.
Representative Parrish. Let me ask you a question on the contracts that the CMOs have with the state. What period of time is that for?
The original contracts, and keep me honest, Kathy, they're one-year renewals every time at the convenience of the state.
Right, but it's basically a one-year
That's right.
contract.
With 7 renewals.
Right,
so we're in year 5? Yeah, we're in year 5.
Okay, well, let me ask you this.
We got 5 more years left, I'm sorry.
With the information that you gave us earlier on the cost of the dental program, when it's time to renegotiate or to renew the contract with the state, taking that into account, what should the state expect from you in your request for renewal as far as the cost?
The role that we play is we try to educate the state and their actuaries to address the concerns and the issues that we have. We know that the state expects that cost will increase in a certain way, but it's our job to decrease those costs. There's a lot of assumptions and discussions relative to that, and we try to share all of our information with the state based on what we think the right answer is. They take that information, they use an independently hired actuary to address that, and then basically once they determine what rate we should get, they amend our contract and update our rates going forward. Kathy, is there anything you want to add on that?
We take that seriously enough that at the current time we have 2 independent actuarial firms that we are looking at evaluating their expenses and their experiences to make an assessment about new rates.
Well, I don't think your corporate structure is going to allow you to lose the amount of money consistently that you're talking about without some sort of change. And I guess the change is then going to come to the state. If you want us to provide the dental services, what are you going to pay us? And my question is, how much is it going to cost? Is it going to be 10% more than it was last year? Is it going to be 40% more? Or do you have any idea?
How much is it going to cost relative to what it had been for our experience or what it had been in 2002?
What the state's paying you now, and what can we look for the state to have to pay you in the coming year?
Well, given that we're still in active negotiations with the state, and that is part of the conversations we're having with the state, and the fact that my competitors are here, I need to be a little loose on that conversation. But what I will say is overall, when we look at the actual underwriting, we're looking at it for taking care of the member in its totality. Behavioral health, vision, mental health, physical health, hospitals, physicians, et cetera, et cetera. Each part of that is a component. There's a cost per unit component. There's a utilization component. There's an administrative component for what we need to do the work we've been asked to do. All that is combined. I don't have a line item that says I'm going to pay you $14 per member per month for dental. But I can say when we looked at what we underwrote and what we bid, what we thought it would cost, dental is dramatically different. So is primary care and a couple other issues. So we're trying to make the best out of a bad situation. And so we're going to go where we think it makes most sense to go and take actions accordingly.
So the answer is you don't know and we don't know.
I know what my dental costs are, and I have a pretty good idea of what my dental costs are going to be after we take the actions that we have, and we've shared that information with the state.
Last question, recognize Representative Henson.
Thank you very much. I had a few questions. One was regarding like physical therapy and that type of thing, because under EPSDT, services are supposed to correct or ameliorate, the problems. Now, when you get it with children with disabilities, you're not going to see that documented type improvement necessarily. So how do you tell the parents, what do you tell them about the improvement of the child and the number of services the child's entitled to and all?
Well, you're right with the developmental delay. We do approve most of those services, just so you know. And we look at the child's baseline, and we are looking for improvement over time. And most of these children do improve over time. And the ultimate goal is for these children to become age appropriate. Unfortunately, many of them do not become age appropriate, but they reach a point where they plateau. Or in a few cases, exceptions, they get a trial therapy for 6 months or 12 months, and there's really no documented improvement. Now, we do pay for maintenance therapy when we do what we're looking for. Number one, if a child is in active therapy, that the parents are involved, and that there's a home exercise program that's developed for the parents to work with that child. And then once the child shows no progress, they've kind of plateaued with services, we would look for that home exercise program to be managed at home by the mom. Now, if there is documented deterioration with that program, then we would approve another evaluation and approve continued services if it's documented that child does need a therapist in order to manage that maintenance therapy. So that is something that we do provide.
Thank you. Another question I had regarding your pay policy, you had brought this up. If a clean claim sent in, what is your policy on processing and rendering payment to the provider?
Our contract requires us to pay clean claims within 15 days. We actually, when we do all of our metrics and report to the state, we really can't determine, it's very difficult to define what is a clean claim and what is not a clean claim. So we include all claims. Our goal is to process all claims within 15 days. And when we don't, we pay interest, even if it wasn't a clean claim. Now, sometimes it does require us to make a denial for claims that are not clean. We do deny claims. I don't have that data right in front of me. But the greatest reason why we deny claims is not a covered benefit, member is not eligible, or it's a duplicate claim. Vast majority of our claims are for those reasons. The rest are for administrative issues like a code is not on the system, and we communicate that back to the provider. Again, a new 120 days start from that point.
Okay, and my last question is regarding credentialing and acceptance of new providers into your system. Are you treating physicians the same way that you're treating dentists and not allowing new providers to sign up?
Not at this point in time, no. We don't have that policy at this point.
You don't have the policy for physicians?
No.
But for dentists?
Yes.
Now, I get phone calls all the time from folks throughout the state, and there's a dentist who just decided to buy a practice or to open in one of our more rural South Georgia towns. Did he make a mistake because he can't get credentialed with you, or will it be okay if there's not enough providers in the area? And then tying into that, could you explain your distance formula with X number of dentists or one dentist per X number of miles, rural and urban?
Right. I'd be happy to answer that question. As I mentioned twice before in the two DCH dental advisory committees I went to, we had this conversation, and the way we have this policy is still the same. We have some concerns given the fact that the reimbursement of the fee schedule in Georgia is relatively attractive to other states, that a lot of dentists are going to see this as a great opportunity to come into the state and work in the state. So we're a little concerned about expanding our network. But we're always limiting that decision based on our accessibility for dental services. So in your case, where there is a potential lack of services in that area, we will absolutely let that provider be added to our network. Do we need more dentists in Fulton County? No, we don't. Now, I know another thing you brought up yesterday was, what about a provider that's expanding or replacing a retiring physician or somebody that passed away or selling their practice? In those cases, we take those on a case-by-case basis, and those are incorporated. So if you know of any cases or any situations like that, we'd be happy to address those with Doral and look at incorporating them into our network.
So there is a gray area. It can be done on a case-by-case basis, but if someone's wanting to buy a practice and they come to you and say, we're looking at buying a practice here or coming in there, how long a period of time would elapse before you could give them an answer, yes, you can come into our network, or no, you cannot come into our network? Because, if someone's looking at buying something, they can't wait 6 months for you to say yes or no that they're coming into the network.
It won't be 6 months. We'll get an
Okay,
answer
but
a lot
what would
faster
it
than
be?
that. I couldn't tell you what it has been. I don't know that we've had a lot of experience with that, have a lot of requests for that. Generally, the answer is going to be done relatively quickly because we know what our network is.
Craig, thank you very much. We've got to move on. If anyone has any more questions from legislature, if you would submit them to me or Representative Chanel, we will get those answered for you. I will turn it over to Representative Chanel.
Thank you, Mr. Chairman. We have obviously jumped the track time-wise, and we will do our best to catch up as best we can. In light of that, as relates to the next two presenters, I think it's pretty obvious that the members are primarily interested in asking questions. However, take as long as you want to do the presentation. Chairman Goggins and I are going to do our best to accommodate the members, and along with Chairman Goggins' request, if you would, members, please, as the people are making their presentations, be considering your questions, and please try to limit it to 2. Senator Goggins and I will stay here till the cows come home, if that's what y'all want to do. But we have miscalculated. We're supposed to be out of here by 12, and we obviously not going to be able to. I'm not sure if it's another meeting in here or what. But anyway, having said that, WellCare is next up.
Thank you, Chairman Chanel, Chairman Goggins, and distinguished guests and members of the committee. We'll try to be very expeditious in going through our presentation, which is being handed out to get us back on track. Good morning. My name is Mike Cotton. I am the Chief Operating Officer of WellCare of Georgia. We are here in Georgia as of 2006, as the start of the CMO program. We actually operate in 7 states for managed care for the Medicaid population. We're a diversified managed care company working with government-sponsored programs. We actually have 2.4 million members throughout the country focused on Medicare, Medicare Advantage, Medicare Coordinated Care, and Medicare Part D programs as well. Within the state of Georgia, we have over 17,000 providers. Our primary care provider network is comprised of 3,500 physicians, 18,000 non-primary care physicians, 159 hospitals. We actually operate in 7 offices throughout the state, with offices in Atlanta, Savannah, Albany, as well as Augusta, as well as Columbus, Macon, and Gainesville. We are a statewide managed care program providing services to about 449,000 enrollees. We've got a number of partnerships that we're proud of that we work with providers. Our network is comprised of many of the key providers and acute care facilities that are important to providing services to the population. You can see some of the names there. We believe that we're focused on being provider-focused and provider partnerships. We'll talk about that a little bit in our presentation. We believe that is the way to be successful in this program. It's a formula that we use in other states as well. Just very briefly, I don't want to spend too much time on this. I think Kathy did a great job, but as we look at why managed care, why our CMOs here in the state, it's really focused on a couple of tenets. One, to make sure that the resources that are available to provide services to the population are used in an effective and efficient manner. We also want to make sure that we do this in a manner that promotes and provides quality to the patients. At the end of the day, we're here to focus on the patient base, and that is what's important. We also looked at the fact that there were uncontrollable costs. The trend rate that was happening in Georgia was unsustainable, and the goal of the managed care company was to come in, be able to manage those costs, and do it in a way that's effective and efficient. Again, not spending too much time, but I thought this slide would be important as we looked at the tenets of the program. Utilization management is one of the things that we have to do. It's something that managed care companies do. It's something that we do as CMOs. And managing that utilization is as important as a basic tenet of what we do to be successful as almost anything that we have, as the chairman said, in our toolbox. We believe in provider-partner relationships as being the foundation of our program. That is the basis of how we can be successful. We look at a number of things in terms of care coordination. Care coordination is the basic approach that we use to interface with our members, work with our providers, and work with our population to make sure that they have appropriate access to care, can access services, and do it in an effective manner. For example, we have on-site case management for our NICU cases. NICU services is one of the highest cost drivers when we look at the population here. And we have nurses who are on site working with the hospitals, working with the members for care coordination and discharge planning to make sure that those most fragile patients are well managed and managed effectively. We'll spend a little bit of time about ER case management. That was an issue that came up yesterday. We do use a prudent layperson criteria. We'll talk about how we use that. We'll talk a little bit about the genesis of that. OB case management is another important aspect for us. The best way to prevent a high-cost NICU case is to make sure that you're doing effective and efficient OB case management and care management. We do that internally. We also use an organization called Matri as well, where we identify those pregnancies very early on, outreach, educate, and make sure that we're able to go out and work with those expectant mothers and make sure that those babies are carried to full term. We also have an extensive member education and outreach program in each one of our offices in the state. We have employed outreach educators. There are community outreach educators as well as member outreach educators. These folks are focused on reaching out to members, doing part of our education and promotion in the communities, and making sure that as we follow up on issues around ER, around primary care services, making sure that transportation is available, they are the touch points for our members to make sure that they have access to care and access to services. Finally, we have a 24-hour nurse triage line that we use. Our members have access to that on a 24-hour basis. If there is a question or an issue that a member may have regarding a health care service, we encourage use of that service so they can get that answer instantly. We find that many times it precludes and prevents an emergency room visit or an inappropriate visit, and also provides good advice and a good backdrop for our patients and members. A little bit about ER. One of the major issues that we identified early on when coming into the state of Georgia is that emergency room services and that utilization has been extremely high. It's higher than any other state that we operate in terms of overall utilization and scope of services. It's higher than what we've seen in other commercial programs. It's very high. We have attempted in a number of ways, and we'll go into that process of how we do that, to outreach and educate our members on what is the best use of the ER and why it should not be used as a primary care site or location. When we look at ER utilization in Georgia, and we looked at this data before coming to the state, we've seen that some of the basic reasons why the population went to the ER were for the basic things that you see here: fever, ear pain, common cold, and headache. These, based upon prudent layperson terminology and definition, would not constitute an emergent condition. However, if you're a prudent layperson, you're not sure whether or not your ear pain is a headache or if it's something else. So we ask and encourage our patients to go to the emergency room. We look at that information and work with the providers and the members to evaluate that as part of our prudent layperson process. In the past in Georgia, ER claims were processed based upon a list of diagnoses. Those diagnoses had very many diagnoses that were commonly referred to as ER and could be identified as ER. There were also some diagnoses on that list that did not constitute what would be commonly referred to from a prudent layperson perspective as an ER. Some of those codes were colds or influenza. Teething was on that list. Sore throat, hemorrhoids, skin rash, urinary tract infection. These are diagnoses that were commonly paid for under the old Appendix F process that the state engaged in prior to CMOs. It should be noted that under CMS guidelines, using this type of list is not allowed. We don't use that. We actually refer to, again, our prudent layperson criteria based upon what a prudent layperson would believe would be an emergent condition. And the state has actually given us definition around that that we adhere to within our contract. That definition, which is noted there in red, as you can see, and I won't go through all the detail, but clearly it states in part, an emergency is a condition that is a medical or mental health condition manifesting itself by an acute symptom. And again, the definition is there. We use this process as, again, we look at how do we evaluate what constitutes an emergency. Well, we can't look at it solely from claims data. In many cases, you have to make that determination by looking at a record, looking at a medical record to understand what were the presenting signs and symptoms. What did the patient or the member feel at the time of the presentation to the ER? That is why we look at ER records, we ask for that information, and use that as a criteria to make a determination for payment. There's a lot that we've done in order to reduce ER utilization. I didn't bring those statistics, but we have seen a gradual reduction in ER utilization. In fact, one of our provider partners that we work with, Children's Hospital of Atlanta, we work especially hard with them because of the volume of ER services that they realize at Hughes Spalding and at the other facilities such as Scottish Rite, etc., where we've seen that reduction come down approximately 10% over the course of the last year. Through this process and with other hospitals, we've identified 10,000 emergency room visits from January through June. And you can see that for the period when those emergency room visits occurred, we contacted those members directly. We have nurse on staff. We work 2 shifts for those nurses, calling members, reaching out, and even using our outreach staff to identify what's happening. Why did you go to the ER? Is there a primary care physician issue? Is there a way that we can reach out and get you transportation? Is there a way that we can set an appointment for you to make sure that you can actually have that appointment? That's the activity that we do through our outreach process. You can see from those calls, we reached about 46% of the population. This is a tough population to reach sometimes directly. We've also been able to assist, as you see there, in some of the other activities that we've identified, referring some to case management as well. When we look at the data at ER services in Georgia, it's phenomenal when we take a look at it and slice the data. We actually have a number of patients, over 1,000 patients in the last 6 months that have had more than 4 ER visits within that period of time. We even have a number of patients who have been going to the emergency room over 30 times in that period of time. What do we do to work with that population? Outreach, education. In some cases, we've identified issues where there were behavioral health problems, perhaps substance abuse problems. We referred those patients to our programs in terms of outreach and case management and actually try to mitigate their ongoing usage of the services. Again, this follows up on our ER management process, somewhat duplicative, but some of the things that we're trying to do. Outreaching for ER calls, member calls, direct member outreach, use of freestanding urgent facilities and urgent clinics. This is something that we're beginning to leverage very much with our providers, our PCPs, paying many of them extra dollars to stay open after hours, paying them a differential if they're willing to see our members after the normal times of office hours are over. We believe that's an investment that's worth making, and we think it's also making a difference. Another aspect that is important and that we heard yesterday is quality, and a lot of questions around how good of a job are we doing as CMOs in making sure that there is appropriate quality and we're providing quality services. We actually look at this and are really diving into this very hard. We're going for NCQA accreditation. That's very important to us. We don't want to just receive accreditation. We want it with commendation. So there are a number of factors that we're looking at. For example, we talked a little bit earlier about how do we share information to make sure that there's not duplicity in terms of data and records. Well, we work with our primary care physicians. We've gone out and done out reviews in the offices, and we're making sure that data and information is shared between primary care physicians. If a member is joining our program or switching primary care physicians with us, we want to make sure that the medical record, that the information about allergies or any issue with that particular member is transferred as well as seamlessly and as effectively as possible, and that's something that we hold our primary care physicians to. We also believe patient safety is important. There are some providers, after we go out and do a review of office settings, we may decide that perhaps there are issues with that provider. We want to make sure that those issues are resolved, and they're resolved in an effective manner. And so we do go out and do those types of reviews as well. From a health check perspective, this is perhaps one of the most important metrics that we work with the state on. We want to make sure that every child receives their health check exams at the appropriate times, on time, and that this is part of the core of what our primary care physicians are doing. We're very happy as we look at our data, over 95,000 of our members are receiving those EPSDT exams in the first 90 days as a result of our calls, of our outreach, of our education process, and continuing to make sure that those exams are happening on a timely basis. Other aspects of disease management. We're focusing in three primary areas. At this point, we'll be adding ER in the next couple of months. But at this point, asthma is a major issue that we're dealing with our population. We've identified through our data over 15,000 cases of members where we have severe asthma issues. We've actually put 96 of those into our intensive case and care management process, where we're monitoring daily, especially with the heat and some of the other issues that have been going on. Are you getting your medications? Are they coming to you timely? Is it coming to you when you need it? Are there other issues that are addressing or affecting you in terms of providing services? Something as simple as air conditioning. If the air quality is bad and you can't go outside, how can you make sure that you're getting the services and getting the type of care that you need, and making sure that you're preventing from having an asthmatic attack? Diabetes, we've identified 4,246 members that have cases of diabetes, and 122 of those are currently in our care management process, where we're focusing on education, making sure that you take your insulin on time, eating habits, nutrition. Why is that important? We've coordinated with our home health agencies and our outreach staff that we do periodic visits in the home with those members to make sure that they're getting the services and managing their diabetes appropriately so it doesn't result into a costly episode. Finally, lead screening. This is something that's become more pronounced as you look at some of the news articles out there about toys and what have you. We've identified about 136 children who have high levels of lead in their blood, focus very heavily in terms of getting these children the type of treatment and services that they need so that they can deal with that condition and be effective and remunerate what's happening from them in that perspective. From a quality perspective, this is a score. These scores actually go to our board. They're very important as we look at our medical advisory committee and our board. This type of oversight on these two metrics are key for us. EPSDT compliance, you can see from the fourth quarter, has risen slightly below 95%. That is a metric that we'd like to see up to 100%, and be working with our providers over the course of the next several months to help encourage that. And then we look at lead screening percentages and the level of testing, how we're helping to facilitate that and make that happen more effectively. Again, our outreach activities, reminder calls, calls to our providers, and again, making sure that members understand the importance of EPSDT as well as getting these appropriate screenings. Heard a great deal yesterday about service. We think service is very important, having appropriate grades of service, answering the phones, and as Craig indicated, not just answering the phone quickly, but making sure that we have someone who can answer the question and give the right answer at the time of the call. This is an area where we've put a lot of focus. We are not perfect in this area as well. As Kathy mentioned yesterday, if you look at the Medicaid manual, there are a number of policies and procedures, many of which we feel we understand, but we can always do better in getting better understanding on those. We are constantly retraining our staff, putting them through secret shopper episodes and making sure that they understand exactly the policies and procedures so that when a member or a patient or a provider calls, their question is answered the first time. And that's an area where we've had a great deal of success in recently with our training initiatives. You can see our time frame in terms of average speed of answering calls. We have splits for all of our services. We break out our members and our provider data based upon our call volume, and you can see we also have data for our pharmacy calls as well. Claims processing, this is an area where I believe we've done a very good job. You can see here from a clean claim perspective, we've processed almost 100% of those claims prior to the 15-day limit that's stipulated in our contract. We have 86% of our providers are submitting claims to us electronically. We worked very hard initially with a number of providers. We worked with some of the associations, for example, Hometown Health. We went out, met with their hospitals, had our data people working with them directly to make sure that they could submit claims to us timely at go live. That was something that was critical and one of the factors why in many instances with those facilities we were able to receive and process claims at go live. From a total claim volume, we've processed over almost 5 million total claims, processed, paid. We have about 200,000 claims, a little over 200,000 claims that have been submitted as duplicates. Some of those are paid, some of those were denied, and another 275,000 that have been denied. Our top denial reasons are eligibility, member not eligible, either a duplicate claim or those services were not authorized. We believe that the standard that we have here in terms of denied claims, we're running right around 5%. We think that's a very good standard, and as we've checked with the Department of Insurance, that standard really is commensurate with what we see in the commercial population. Authorization processing is also critical as well. Our goal is to get all authorizations processed within a 5-day period. The state standard is 14 days. We also have a goal of getting 90% of those processed within 2 days. Over the course of the year, we've been able to meet that standard. In most cases, we've had a couple of months. As you can see, we're at the 86% level, but overall, we've been able to adhere to this goal. We have on staff nearly 70 people who are involved in taking authorization calls for all levels of services, be it therapy, hospital, outpatient, home health, pharmacy, etc. And again, those metrics, as you can see there, reflect our hard work in that area. From a community perspective, we think it's impossible to be an effective managed care company serving this population if you are not involved in the community. There are a number of things that we do and that we offer and provide. Some of them are subtle. We are very focused on making sure that what we do is focused primarily toward healthcare services delivery. In Savannah, for example, we've teamed up with a number of community-based organizations, and we're promoting fitness, and that fitness is driven toward exercise, getting appropriate exercise externally. You can see there that we're part of a step-up program, a number of agencies that we work with, juvenile diabetes, faith-based organizations, as well as just basic communities as well. We also believe that that partnership should be also manifested in what we do in providing services and making sure that services are always available. And we've started a process with a number of organizations as we'll be working with the foundations and other community agencies and providing partnership funds to make sure that those needed services can continue due to funding perhaps underlays or other issues. We want to step up and be a partner with those providers and put our dollars out there to be able to support those programs that are necessary and effective. A little bit about, and this is a pretty busy slide, dental has been an issue as well. Access is something that we believe is very critical for our dental program. We have implemented one change in our dental program. That change was related to how we're paying for fillings and a couple of other issues around visits. We've looked at the access for our network. We're showing you here that we have a couple of providers, more than a couple providers, if you will, that are in those key areas that are related to one of the key providers that was testifying yesterday, Cool Smiles, and we just want to be very upfront about that, that is important to us, that we've validated that evidence, that we have access. We validated that not only through direct calls and communication with providers, but getting those providers to attest that they are willing to see patients and that they're willing to see our patients on an ongoing basis. Measuring success for our program, we see it in a number of ways. Strong positive relationships. high member satisfaction. We have information on our satisfaction surveys. We didn't incorporate into this slide, but clearly our members are very satisfied with what we're doing. We see that in our rates of choice. We see that also in our member retention programs and outreach. We believe government partnership and collaboration is important. This forum, we believe, is important in terms of exchanging ideas and working with the state as well as the legislature and key community agencies to make sure that we have a dialogue and we can continue to be better at what we do. A little bit on the provider side, we actually meet with providers on a weekly and sometimes a monthly basis. We have a number of work groups that we've incorporated in our process with Children's Hospital of Atlanta, some other groups in other areas as well. We sit down with them on a weekly, monthly basis, go over issues. Sometimes those meetings are very fast because there are not a lot of issues. Sometimes those meetings take a little bit of time because we have to work through those issues, but we have staff committed to making sure that we do that. We believe service is important. We'll continue to be focused on service. We're looking at ways to enhance that as we speak now in terms of staffing, in terms of technology as well, and then making sure that we're part of the community and staying involved in all activities within the community. I tried to do that extremely fast to get us through in time, but that concludes my presentation.
Thank you, Mr. Cotton. I have one question I want to ask you. You all are in all of the regions, is that correct?
Yes.
So you cover rural Georgia. My question relates to something that's pretty specific to rural Georgia, and that is, I think we heard testimony yesterday that out of 35 critical access hospitals, 33 no longer deliver babies. I think that's right. Something close to that. So what that really means is in rural Georgia anymore, there's just not in place hospital that's not delivering babies, and for obvious financial reasons. My question is, as it relates to prenatal care, I mean, the 4 counties I represent, every pregnant mother has to go someplace else. What I'm concerned about is not appropriate prenatal care that then could lead to having children in the NICU unit. It's, as you know, very, very expensive. My question to you is, what, if anything, are you all doing to address that problem?
Well, that is a very large problem, sometimes a little bit outside the scope of CMOs, but what we're trying to do is to work with those providers who are able to provide OB services. There are some family practitioners who are willing and able, because of training and expertise, to provide those services. Nurse midwives are also able to provide those services. So we're doing all that we can to encourage those providers to render services to our members and to patients in those areas. In some cases, that means we will actually pay those providers a differential if they're willing to see our members in those areas and to make sure that they can receive care. So it speaks to trying to attract and bring those providers and encourage them to practice there, and also making sure that that access is there with a fair reimbursement.
Well, you said it's outside the scope of CMOs. Maybe it is, but if they're delivered, since you're in every county, if they wind up getting delivered in the NICU unit, it is within the scope of what you're going to have to pay for.
Absolutely, if they're a member. Absolutely.
No. Chairman Goggins and Mr. Chairman, the chair will make an exception. You can ask as many questions you like, sir.
Thank you, Mr. Chairman. I appreciate that. Thank you, Mike. I want to read something to you, Mike. And it says DCH hired a consultant to review the CMO's respective claims payment systems and ER claims that have been processed. The final report confirmed WellCare's automatic claims payment system pays over 80% of emergency room claims at the non-emergent triage rate. WellCare achieved this result by programming its system to recognize only a small number of conditions as emergencies, while not considering critical factors such as day of the week, weekend versus weekday, time of the day, or member age. First of all, I'm going to ask you, is that correct or false? And then I'm going to ask you the same question that I asked the previous speaker. Are there any systems or programs that you have in your company that delay or deny first initial claims or delay claims being paid?
So for that, your specific question, there is no systematic process that we have nor that we want to deny claims. We try to look for ways to pay claims in every instance. In terms of the report in our ER review, we were audited by the state in terms of how we pay claims on an ER basis. We look at every aspect of how we do that. We don't deny any ER claim. We pay a triage rate. And our goal is trying to work with providers to come up with ways to be effective as those claims come in to pay them appropriately. We can ask for records, but we try to look at every aspect on the UB92 that allows us to pay for the claim.
And do you agree, though, on the appeals process that the hospitals usually were right?
We have a turnover rate that runs about 50-50, and a lot of it really depends on the facility. Some facilities are running slightly less than that just because of the scope of services they're providing. Some are running a little more. But it's about a 50-50 turnover rate in terms of what we see.
Okay. Well, I think I got an answer to this problem here. I think what we need to do is, for the DCH board member, is that when the emergency rooms file these claims, they get paid at 100%, and then they get to hold the money until it's proven otherwise. What would you think about that one?
That's definitely within the purview of the committee and the legislators.
We'll look at that. Also, there's just some behavior from WellCare I want to talk about that I guess I'm a little concerned with from a standpoint of closing the panel of practitioners, from a standpoint of termination of practitioners, with the language of your contract will be terminated if you do not agree to the terms. And that's pretty harsh. There's some, I remember when we were talking about the subcapitation, there were dentists and other providers that wanted to stay in the program but did not want to go to subcapitation. And so they wrote in letters, handwritten letters, saying, we would like to stay with the program, but we do not want subcapitation. And so there are many instances where people were terminated just because they did not agree to the new contract changes. Also, a little concern with the behavior of the recoupment, and that these individuals went online, they saw where the patients were approved, the work was done, and have come back and said, and I agree, y'all stopped it, I appreciate that. But that's no different than the state coming to you and saying, well, there's not that many patients in there, but you've already taken care of them, so we're going to ask you to give us our money back.
The state does do that, by the way.
Okay. Well, we may have to continue. But I'm really concerned with some of that. Also, the Patient Access Eye Care Act, WellCare was not aware of that?
That's not true. We're aware of the act. As we look at changing our vision program, we have looked at a number of aspects of what's the best way to provide services, and we have changed our policy at this point where those services are still being done through Avisus.
Okay, and the reimbursement rate is the same for the optometrist and ophthalmologist, or is there a difference in the rates?
Avisus reimburses those providers. That's outsourced, and they pay the same rate for optometrists as well as ophthalmologists through Avisus.
Very good. From a standpoint of the dentistry, still concerned with the, I guess, the tax on the board saying we have adequate network. Explain to me how we have an adequate network when I know individuals that only see so many Medicaid patients. They're not full Medicaid offices. And how do you come up with that? And we know I asked the same question yesterday to Kathy. You only have so many children in this program that needs dentistry. Mm-hmm. Why does it matter how many dentists are performing those? There are many dentists that want to do it as a service. Obviously, they don't make much off of it, if any. What does it matter? Why do we have to limit? Why do we have to close our panels? Why do we have to terminate individuals just for that reason? And then also, I do want to ask you, and you may not be able to answer this because of pending litigation, but we have a group that their entire business model is treating Medicaid and Peach Care. That's their entire business model. And if they're dropped, I guess I would assume that their business, is gone in the state of Georgia. And they have come back, and here again, I'm not understanding why they're going this far, but they're offering even further fee reductions, capitation, which to me is not the greatest. But is there any where we're going to work with these individuals to keep them seeing the kids of this state?
Well, a couple of questions, Chairman, if I may. First, we don't capitate providers. We pay them fee for service.
I'm just saying they had offered.
Okay.
I mean, they're offering to take less.
Okay. So let me go to your last question. I may have to ask you to repeat a couple of those. As we look at access, we look at the criteria that the state has dictated for us for dental care. We also look at what would be an appropriate level as well. When we look at access for our providers, for our members within the areas for the provider that you're referring to, we meet those standards and actually exceed them. The genesis of our decision to work with or not work with providers were based upon modifications that we made to our program back in May and June. Of the 848 payees or providers that we pay for who were given that information, 822 of them accepted those right off, and we looked at our network access and said that meets our criteria, and we were comfortable with that. We did receive information about differentials in terms of reimbursement. I don't want to go into that in full detail, but I can tell you we're comfortable with our access. We're comfortable with the providers we have. We've gotten them to attest to their ability to see those patients. We've gone to those offices, and we will continue to monitor that and make sure that they can.
Thank you, Mr. Chairman. Thank you.
Representative Shaw. Representative Stevens.
Thank you, Mr. Chairman. I know there's issues in lots of other provider areas, but I just wanted to give one positive spin if I can. Since day one, of the two providers that we've got in our area, it's been seamless as far as the eligibility files, and even more important, the ability for us to get in touch with your company on the weekends and after hours, which is kind of refreshing. It does not leave the patient kind of hanging. So from that point, and from pharmacy and the eligibility, I just want to say thanks.
Thank you.
Representative Henson.
Thank you, Mr. Chairman, and I do have a few questions. Needless to say, they'll deal with dental. But I'm just going to bring out names, but beside Cool Smiles, how many other dental groups have been terminated from your network?
There were 26 payees originally that did not take those modifications. We've actually been able to work through issues with 2, so there are 24 groups now.
And approximately how many dentists are involved in those 24 groups, since you do have listed the different dentists at those locations?
The number, and I will double check this to be very clear, but I think that number is somewhere around 124. But okay. I will validate that for you.
Now, if all the children that are being treated by these 124 dentists go to someone else, are taken in and get treatment from someone else, could you please tell me what you have gained with regard to your bottom line and finances? If all these children do find another dental home and do get treatment, what will you have gained financially?
If all of these patients receive services and care, which we want to have happen, we hope that will be what we're seeing now. People getting access to care, good quality. We're actually going to be promoting and actually in that process now, directing our members and contacting them to make sure as we transition they can actually have access to a dentist. So that's something we're doing now over the course of the last week, and we'll be doing for the next 6 weeks, making sure that people have access, they get their appointments, they keep their appointments, and they continue to receive dental care.
In all reality, and I've worked with group dental practices that are Medicaid since 1980, I do not believe that you can get that broken appointment or missed appointment for Medicaid population down below about 35%. I've worked with groups that have tried very, very hard to do that, and the only thing I can say is, looking around this room, there but for God go any of us. I mean, seriously, we're just very, very fortunate not to be encumbered with many of their problems and their life situations. And I greatly question how a small provider can cope with that heavy broken appointment rate and go for it. But I have one last question.
Where's the question, Representative Henson?
Okay, and then I have one last one that'll be real quick. And that is, I'm going to ask you for a request. Since it's my birthday, I really thought it'd be nice to get a gift, and I was just wondering if you'd consider reinstating all those 124 dentists that you've terminated as a birthday gift.
Well, I really want to wish you happy birthday.
Representative Gardner.
Thank you, Mr. Chairman. Tell me about the services for mental health that you provide, particularly the authorization for medications and psychological testing.
We actually outsource our behavioral health services to Magellan, but we also have our own company that works very closely with them, Harmony Behavioral Health, and we're actually working in tandem to make sure that medications are available. We have joint work groups with our in-source organization working with Magellan and our medical advisory committee to make sure that medications are appropriate, they're being dispensed appropriately, and that there's good collaboration with all of our providers.
So the medications are approved by WellCare?
WellCare, we have our own drug list, and we work in conjunction with Magellan and our behavioral health care company to make sure that they're available and appropriate.
So they provide all the services except for the approval of the medications?
That's correct.
What about psychological testing? I've been told just recently in the hall by someone who suggested that they couldn't get psychological testing approved even for somebody who was an sexually abused child.
We do cover psychological testing. Again, Magellan has a criteria that we dictate. If there is an issue with that, we'd be more than happy to look into that specific case.
I'd appreciate it.
Absolutely. We'll get information.
Representative Hughes.
Thank you, Mr. Chairman. I only have one question. The other company, AmeriCare, spoke to their financial loss that they've experienced in Georgia. Have you had a similar situation, or what has been your experience this year?
We're a publicly traded company, so we don't speak openly and comment about specific states. I can tell you for every dollar that we receive, we pay out about 88 cents to 90 cents for health care services. There's a portion of that, about 6 cents, that we pay back to the state as part of our agreement, and then the rest is left for us to do in terms of administration and margin.
Thank you very much.
Thank you.
Peace State.
Good morning. Chairman Chanel, Chairman Goggins, and members of the Joint Committee. Thank you for the opportunity to be here today to present. My name is Chris Bowers, and I'm the President and CEO of Peach State Health Plan. Before I get started, I would like to make a few general statements. As Craig mentioned earlier today, we did pay a lot of attention yesterday to a lot of the comments, and we do take all of the issues that came up yesterday very seriously. I think if we look back, the Georgia Families Program is now just about a year old. And a little over a year ago when we got started, the CMOs, DCH, the providers, we all really started from scratch. I think Kathy Driggers mentioned yesterday the size of the transition. Mistakes were made. And Peach State, we made our share of mistakes in the implementation as we got started. We're certainly not happy about it. Since then, we've made significant steps to correct a lot of those errors, and we are committed to working through the issues in a methodical way with our partners, the providers, and DCH. It's really not unusual to have problems in a startup of this magnitude, but the thing that we need to keep our eye on is the long-term success is going to be our ability to work together collaboratively as we move forward. One thing that I'd like to mention is the fact that I think you can look at managed care as a systematic approach to analyze and share data with the department, with our providers, which is really going to enhance the quality of care to all of the citizens of the state of Georgia. The agenda that I've got this morning is pretty brief, and I'll do my best, as Mike did, to get through it quickly. I'm going to talk a little bit about our goals, a little bit about the Peach State Health Plan. Access was a big issue yesterday. I want to address that. I want to talk about quality care and appropriate utilization with our ED management program, review a little bit of our disease management and member programs, talk about member satisfaction, and a few health plan operations issues. Kathy did a great job yesterday, I think, leading us all off with the goals of the department. I think if you take a look at our goals up there, they match pretty well to the state's. Providing access to quality providers of all specialties. Improving quality of care to our members. Dr. Nair talked about that yesterday. Appropriate utilization. I think we've all heard the right care at the right time and at the right place. And then also to maintain our outreach programs with our members. Peach State currently serves about 280,000 members. We have over 10,000 providers. We employ 226 folks in our local offices. We have 4 of them here in Georgia, Columbus, Macon, and Albany, and we believe we have contributed to the savings for the state of the $78 million. Here's a quick map of where our regions are. We're in 3 of them, Atlanta, the Central Region, and the Southwest. Atlanta, we currently have 156,000 members, Central Region 52,000, and in the Southwest we have 73,000 members. Access to care, big issue yesterday, but it is also a very, very important issue as we look forward. And I wanted to share some of our access information with you this morning. First, let's talk about physician access. We have gone beyond the industry standard for primary care physicians in terms of how many we have per number of members. The standard in the business is 1 to 200 members. We're at 1 to 75. We almost have 2,500 primary care physicians in 3,800 locations. Kathy put up yesterday the fact that we've got 7,000 specialists in over 12,000 locations. We meet all of the DCH access requirements, geo access requirements for primary care physicians, and we meet almost all of the specialty requirements, with the exception of some of the specialties that have been discussed over the last few days, like some of the pediatric subspecialists like orthopedics, endocrinology. I want to assure everybody that we do talk to the department routinely about these issues, particularly the pediatric subspecialists. And when we do have a situation where we don't have a pediatric subspecialist to handle one of our members, we do work with the providers on single case agreements. We work with out-of-network providers in order to make sure that that care gets provided. Continuing with physician access, we do a lot of surveys. I think everybody here does secret shopping after the last few days, so we do it also. But we do some surveys. And those surveys, I think, are pretty telling. We take a look at what's available within a 24-hour period for sick and well child visits. And you can see up in the mid to high 90s. OBGYN accessibility is not quite as good at 83%. And from an urgent care standpoint, you can see that it's at 91% for our providers. I think this information here really helps validate the geo-access information that we've provided to the state. Now, one of the most controversial topics we've had the last couple of days is dental access. We are committed to ensuring access to quality dental care for all of our 280,000 members. Currently, we have over 900 dentists in our network. We exceed the DCH geo-access requirements. We've done a recent sampling of our dental our dental providers, and 92 of them have a routine appointment available within 30 days, and 84 of them have an emergency appointment available within 24 hours. Again, we think that this recent sampling of our dental network helps validate the geo-access results, again, that we've provided to DCH. From a quality and appropriate care standpoint, I want to talk a little bit about our emergency department management program. First, let's just talk about the goals, and they're pretty brief and I think pretty straightforward. Reducing inappropriate utilization. This is critical. We've heard it yesterday. Influence the members' behavior. One of the most difficult things to do. We've gone through years and years where the Medicaid members have felt that the emergency room is the appropriate primary care place or the only primary care provider that they could have. We've got a lot of work to do to educate our members, and it's not easy. In my experience in this business is it's not going to happen overnight. We look at it as at least a 18 to 24 month process before we can really start to have a significant impact. I was very impressed with the results that I've seen from AmeriGroup this morning. Appropriate level of care. We really want to educate our members as to utilizing the primary care physician, utilizing the urgent care centers that are in their area. Now, how do we accomplish this? It's a pretty straightforward program. We believe that you've really got to start not only when you have a welcome call with a member, but particularly when they get to the ED for the first time. So when that happens, a welcome letter with the PCP is identified. We also send out educational materials. We send out the urgent care centers that are in their areas. We step it up a little bit more when we have 2 or more ED visits. We have our case managers calling. Again, education. And there are a lot of times where we find, for instance, in asthma, where we're seeing multiple visits to the ED because of asthma. That would then would generate a referral into our disease management program. But after about 10 days, if we haven't heard from folks, we have some outreach education folks called Connections, and I'll talk about those folks in a minute. And we refer to Connections for a home visit. And we do our very best to get in front of those members by going out and visiting their home. We also, at the same time, are notifying our primary care physicians or their primary care physician of the fact that there are multiple emergency room visits going on, so that when they happen to get to the primary care, they can also help educate. What have our results have been? We think it's a little too early to tell. We know there's a lot of seasonality. We know that there's more emergency room visits in the winter than in the summer. We look at the fact that we're getting our first year of baseline in place. And again, as I mentioned earlier, we think it's going to be an 18 to 24 month process before we can feel comfortable that we're making the type of changes that we want to see. Disease management, Dr. Nair talked about that yesterday, requirement in our contract. I'll share some of the early results that we've had. First with asthma. The left-hand bars you can see are the number of unique members that are in our asthma disease management program over the last 4 quarters. The members are really targeted for education, identifying what preventative sorts of services and activities that they should be involved in, and treatment options. Some of the early results, we've seen a fairly significant reduction in ED visits, fewer hospital admissions, and a fairly significant reduction in lost work days for the parents of those children. Diabetes management, our next one. We're real happy here. The participation in this program continues to go up. Again, here it's not quite as great, but we've seen a 6% reduction in the ED visits from the last half of 2006 to the first half of 2007. But we've seen a fairly stunning 32% decrease in hospital admissions with regards to diabetes in that same time frame. We're anxious to get some of the HEDIS data that Dr. Nair referenced yesterday so we can look at some of the more clinical outcomes of the program. Probably the most important program, not that they're not all important, is the issue of OB case management and high-risk OB case management. We know that, I've heard it mentioned here already today, we spend more money in our health plan on OB and NICU than any other segment of our business. The most important thing is early identification. We've got several ways that we do it. I won't go into all of them, but it is one of the key factors here in terms of our success in the program. We have dedicated case managers who look at all of the members' needs. We do some incentives for our providers where, for instance, if they get to all of their prenatal care visits, we have gift cards, whether it be at Target, maybe Walmart. I'm not sure which ones we're using right now. We also use a fairly interesting clinical program when we know that a mother has got a history of having preterm or low-weight babies. We try very hard to work with their particular obstetrician and utilize a drug called 17P, which has demonstrated results of keeping the baby in utero longer than it might have been had we not used the particular drug. So I think it's real interesting. We've got some studies coming out in some journals at the beginning of the year, but it's one of the areas that we think is really important. If you just take a look at the data, you can see in the last quarter we had over 5,000 members in OB case management, and the subset of that is the high risk, and we're up over 900 members now in that high risk program. Member programs, NurseWise is a confidential 24-hour nurse advice line. 100% of our nurses are bilingual. They answer just general health questions. We find a lot of members who will go to their physicians, come back and realize that they didn't ask some questions that they would like. It's a great opportunity for them to just pick up the phone and they can get answers very quickly to some of their questions. And one of the things in the first quarter of 2007, we had 5,000 of our Peach State members use that particular service. Our Connection program is a member outreach and education program. We think it's really unique because in part it's staffed by individuals who have been on Medicaid themselves during the course of their life. And we have found that this has been very, very valuable because they're out interacting on special situations with some of our members. And they relate very well to our Medicaid members, and it really, really works well. We have those representatives in all 4 of our offices. We really look for one-on-one education. They've completed over 400 visits over the course of this year. And they also are the face of Peach State in all of the community events that we participate in and sponsor, such as For Sisters Only, community health fairs with our hospitals, and working a lot with the Boys and Girls Clubs. You've heard about well child visits, ESPD, EPSDT, health check, that goes by a lot of different names. We spend a lot of time encouraging our members to make sure that they get their children in for these important visits. You can see the sorts of numbers that we deal with on a quarterly basis in terms of mailings and calls and how we try to outreach to those members. From a member satisfaction standpoint, just a couple of quick results. We do the same survey as everybody else, an external organization. A couple of the results I put up here. 80% of the members indicated no problem receiving same-day care. I think I put the second one on there again because of the access issues that we've been talking about. We hear a lot of discussion about access, but the members here at least perceive, at least at 94% of them, that we've got adequate access to health care. 96% said they don't have any problems with the paperwork. 72%, a little bit lower, said complainer problems was settled satisfactorily. And 80% gave their children's specialists the highest rating. So we believe that this is early data for a program that's only really been in operation, right around a year, and we're really pleased with the results. Provider outreach. I know we've talked a lot about that, or there's been a lot of discussion about lack of communication, and I'll be the first one to admit it sounds like we could have done a lot better in our communication on a lot of fronts over the course of the last year. But I do want people to understand that we are out there on a quarterly basis with over 800 provider orientations, credentialing site visits. We've hosted 12 town hall meetings. We're considering doing that again. We have joint monthly meetings with some of our hospitals, and that's where we talk about claims issues. We talk about prior authorization issues. It gives us an opportunity to dialogue. And again, we also have a lot of written communications that go out on a regular basis to our providers. Claims processing, that's been another hot topic over the last few days. I wish I could say this was one of the areas that we started out the program in great shape, but we didn't. So I'm here to say that we did struggle at the very beginning of this, and I believe that we have taken some steps to create that. I threw up a few numbers here for you to look in terms of the total volume of claims that we've received over the course of the first 6 months. You can see over 3 million. We've paid almost 3 million of them. Total dollars paid over 300 million. 80% submission by EDI, which I think is pretty good. Our average days to clean claim is 7.7 days. One of the things that we do that I haven't heard anybody talk about is we've got a very systematic process where we look and identify fraud and abuse. It's one of the things the state has asked us to do. I can tell you that right now that we got 16 open cases. We are working with the appropriate state agency on these cases to resolve them with the right type of intervention. Some will probably be turned over to the state for them to investigate even further. Some it's just a matter of going out and talking about billing and coding and some of the appropriate ways to do that. But we think that's a real valuable element of the program that we bring to the state. Prior authorization, there's been a lot of talk about that. This is another area that we had some startup problems. The state came out early this spring and did a routine audit. As most of you have probably read in the newspaper, we didn't do well in that particular audit. We've received a sanction. We are in discussion on an appeal with the state right now, not to the fact that we were out of compliance, but the fact that for the size of the fine. So we're dealing with that. But we have taken a lot of action since that particular situation. We've re-engineered our workflow process. We've dedicated a lot of additional resources to the process, and we've got a lot more management accountability. And I'm confident to say at this point in time we are compliant with the state's contract. We've also heard a lot about service in the last couple of days. Just a few bits of information for you. From a provider standpoint, so far year to date, we've gotten over 140,000 calls. Abandonment rate's a little over 1%. Speed to answer is 19 seconds. The next one should say total member calls of a little over 150,000. Less than a 1% abandonment rate, and average speed to answer is 13 seconds. In closing, I'd like to say is that Peach State is committed to work collaboratively with DCH, with our provider partners, to reach the goals that the state has put out there for the Georgia's Families Program. With that, I'd like to take any questions.
Chairman Goggins has a question.
Thank you.
Or questions.
Two. Are you at this point doing any recoupment of any payments specifically in OB or anesthesia?
We are in the process of looking at doing that. Yes, we are.
Can you tell me why you would be recouping?
Well, I've got an expert up here that might be able to answer that question better than I am, but I'll take a shot at it first. And the fact is that we systematically overpaid anesthesia right from the beginning. And so it took us a while to get the appropriate information from the state, get it loaded into our system, and we've got that loaded into our system going forward. We're paying correctly going forward, but we feel it's appropriate for us to go back and recoup where we have overpaid the providers.
Were the codes given to them? That's what you were paying for that code?
I'd like to introduce Jonna Kirkwood, our Vice President of Operations, who might be able to answer that better than I can.
Hi, thank you. I'll take a shot at it. At the time that we took the original fee schedules from DCH, there were a couple of codes in the anesthesia range that did not have fees associated with them. We therefore didn't load those fees. We have subsequently received the fees from DCH, and in putting those fees in the system, we have, for the most part, overpaid. When we don't have a fee in our system, we default to a discount off of billed charges at a set rate. It turned out that that fee that we paid at a discount was higher than the state's Medicaid fee schedule. There are a few situations, and not the majority, in which we underpaid, and we will also go back and we will repay those at the higher rate. So we are going to re-adjudicate anesthesia claims for the two codes that were impacted and pay more or recoup some of the fees back.
ask the other question. As of all the other, is there any systems that you have that slow down or deny initial claims?
No, that we do not, sir.
Representative Stevens.
Thank you, Mr. Chairman. Following on Senator Goggins' question earlier about the spiraling admin costs that seem to be something none of us anticipated. Since the department's got an admin cost, and then we've got you that's got an admin cost, and as it relates to dental, we've got two other subcontractors that's got an admin cost. And of course, dental specifically seems to be a drain on the revenue sources for each of you. Would you have a problem if we just went in and carved it out?
Our philosophy is that we don't really support carve-outs because we believe that we need to take care of the continuity of care of the member from start to finish without regard to what the service is. So we particularly do not support a carve-out.
Okay, and one more, if I may, Mr. Chairman. My second question has to do with why you're not in Southeast Georgia. We've only got two providers there, and when is the soonest possible time that you can be there?
Well, that is not necessarily our decision. I would have to defer that to the department, and they could address that.
I'd like an answer on that, even if it comes from the department.
Did you get your answer, Mr. Chairman?
You want to know why we only have two providers in the Southeast region? Well, the decision was made when the program was designed that we have to provide choice, and choice, as far as we're concerned, is two. We are also looking, part of what went into making that decision is volume of lives. There really there's not a sufficient volume of covered lives in the Southeast region to support three different plans. So that's why all three plans participate in the Atlanta region, where half of our Medicaid and Peach Care members reside, and why there are two in the other 5 regions because of the volume of lives. That Southeast region, all of the regions were competitively bid, and Peach State was one of the awardees in the 3 regions that they are in. They were not in the Southeast region.
Can I follow up, Mr. Chairman? Just
yes, sir.
One more. Is there an opportunity for a different provider to still have 2? Can one of the CMOs be interchanged?
I would not say interchanged.
Replaced?
There would have to be some very specific circumstances before that could happen, and then there would have to be a lot of discussion with the federal government about that.
Representative Shaw.
Thank you, Mr. Chairman. Mr. Bowers, when something is basically privatized or outsourced, in this case to the CMOs, I understand you have like 226 employees in Georgia working in Georgia. Would you think that the department would have less work now because they're not doing the in-house?
Wow. I guess the best way I could answer that question would be that the type of administrative activity that we currently do is significantly different than what the department was doing in the Free-for-Service program. We've talked a lot about the types of services that we provide, disease management, so on and so forth. We've got a lot of different requirements. So I don't think the department was doing a lot of these things in the past. So I can't really comment on the efficiency of the department, but I can say that the administrative dollars that are going to the CMOs are going for a very different reason than what had been going to the department.
Well, thank you. Mr. Chairman, may I ask a question? It's not to the CMOs, but to Ms. Riggers.
Yes, sir, Representative Shaw.
Mr. Eggers, you and myself, along with Chairman Chenell, Chairman Stevens, I know the three of us was in a meeting, and a guy named Abel Ortiz, we met in a little round room way back, and we were told that it was going to be a savings for the state of Georgia for the Department of Community Health. Well, in the fiscal year 05, and I wish I had it where we could show the screen up here, Mr. Chairman, we had a budget of $2,292,998,000 some few cents, with 507 employees. That was in 05. That was just prior to the CMOs. And we were told, just wait, there's going to be a savings, and we will show you the savings. Well, we have, Mr. Chairman, the 08 budget for the department, and it is $2,482,000,000. The 07 budget was during the CMO, was $2,655,000,000. Now, we're not too smart farmers from South Georgia, but I can do figures. And that's $509 million increase from the time we went where we were doing it fairly efficient with the Medicaid population. Basically, all we have now is age, blind, disabled, and the state health benefit plan. And we have 529 employees today. We had 507 before it came in. Can you explain to this committee and those of us that was in that meeting where the savings is and why there's more employees? Besides that, the CMOs now are employing around 676 employees to do this work in the state of Georgia, more than we have in the whole department. But where is the savings to the taxpayers?
Representative Shaw, you definitely get the award for putting somebody on the spot. And unfortunately, I am not the person to answer that question for you because I do not run the agency. I think you and Representative Gardner yesterday, those are valid questions to ask, certainly.
Well, I apologize. I would have asked Dr. Meadows, but she's not here. Now, Ms. Summers was in the meeting with us, so she can answer that sometime. But in that particular meeting I was talking about, you, us, along with Commissioner Burgess at that time.
I do remember that meeting, and I think it would be remiss of me to speak on behalf of my commissioner or Carrie Summers on overall budgeting for FTEs for the department. I can speak to my little piece of that. Of that, and that in my little world, that we, the monitoring and outreach activities that we do for the plans and the oversight activities, there are other activities going on within the agency. There are different initiatives that have gone on over the last several years. I cannot speak to the staffing of those, so I feel like that I can't answer your question sufficiently. I can certainly take that back and get that. I do know, I can tell you that in FY06 you made the comment that that was the year that we implemented and the budget was higher. That one of the challenges in an implementation year is that we had to plan for, and we've talked about this before, we had to plan for the prepayment of the premiums to the CMOs while also dealing with the claims run out from a fee-for-service environment. So we were moving from a cash to accrual basis, and that was one of the reasons for the budget being higher in 06. But as far as the staffing levels, that's certainly something that I feel like that Dr. Meadows would need to have that discussion with you.
Well, thank you. Would you agree with me, though, that that's basically a 20% increase in the department's budget?
For the staffing levels?
No, I'm talking about increase in your budget. The figures are there on the budget.
From 05 to 06?
05 to 06, 07, I mean each year. But from 05 to 07, it's a 20% increase.
Well,
and the staff has not decreased.
Understand.
Would you agree with that?
Would agree with that.
Okay. With that, Mr. Chairman, I'm concerned. I'm real concerned. We were told they would be a savings. There is not a savings, and we need to get with the House and Senate, both of you chairmen, and with the governor and all, because it's not in the best interest of the taxpayers of the state of Georgia to continue to do what we're doing now.
Representative Shaw, what Jim Goggins and I are going to do is, first of all, as it relates to questions to the department, we talked about that yesterday morning. If we had questions for the department that they couldn't answer, they told us they'd get back to us with answers to those questions, and this is not the first one. There's several. As it relates to CMOs, yesterday we were here until about 6:15. People from all over the state made a large effort to come here and provide testimony. A lot of them had handouts including that testimony, and what we'd like to request the CMOs to do, Margie Coggins will be the point person, but we want the CMOs to also be privileged to hear and to have that handout material. I fully understand contractually you don't have to do anything with that, but Senator Goggins and I would respectfully request that once you get that, if you could, whatever responses that you might have to those concerns, I think it would be something we owe to those folks to respond to them. And also, she will act as the point person for collecting those responses and sending them out to the members. Both the presentations from the people at the public hearing on yesterday and whatever responses we have from the CMOs, you as members will get that for your information. We certainly don't have all the answers and can't respond necessarily correctly to all our constituent concerns, but we're going to ask CMOs to join us in that effort, along with the department as well. Representative Henson, it is your birthday, and I want to wish you a happy birthday, and also as a birthday present, allow you to have 4 questions. No speeches, and keep in mind you're the only thing between us and lunch.
Thank you, Mr. Chairman. I'll keep it to exactly what you requested. Are you accepting any new dentists into your network now? And if not, are there any extenuating circumstances on whether you would accept any new ones?
I'll answer that for you. We do look at geographic need for dentists. I know one of your concerns was dentists buying new practices or buying into practices. If we do have a geographic need in an area, or if a dentist is taking over a practice, they contact us or Avisis directly, and we look at those on a case-by-case basis. If we do have a geographic absolute open need, we would accept dentists into that geographic area.
And if you have a situation where a father is going into semi-retirement, would you allow the child to come in and both of them to be practicing?
Absolutely.
Okay, another one I had, you answered that you didn't like carve-outs, but yet isn't behavioral health carved out and being taken care of by a company called Simpatico? So why are you regarding dentistry different than behavioral health?
It's not. Behavioral health is not a carve-out. Simpatico is part of the companies that we utilize to help cover all of the services. It's not carved. It's in the CMO's capitation that we get from the state, so it is not considered a carve-out.
Okay, and my very last question was, could you explain the fee reductions that you've had since the first of the year? Have you had 1 fee reduction or 2 fee reductions for the dentists?
For dental?
Are this specific to dental?
We've had one.
We've had 1 fee reduction since the beginning of the year.
In July.
Yes.
And the percent of that fee reduction?
I'm sorry, say again?
the percent of the fee reduction?
That's a question that I prefer not to respond to.
Thank you very much. We have had the last 2 days, as all of you know, a view of the implementation of CMOs from the department's perspective and from the public's perspective, including providers and patients, and from the CMOs themselves. Obviously, there's some differences in the viewpoint of how that is working. Senator Goggins and I will continue in our respective committees to do best we can to continue oversight of how this is working. And the likelihood is we probably will have one more meeting similar to this before the end of the year for that purpose. I want to thank all of the members of both committees for your diligence and for attending the meetings. I think, from my perspective, I think we've had a productive meeting, and I want to thank each of you for being here, as well as all the members of the public who've made the trek up here to talk about this very important subject. Chairman Goggins.
I would say ditto to our distinguished chairman, and thank you for everyone being here.
We are adjourned.